My name is Shelley Witt, and I'm an audiologist. I'm a clinician that works in the University of Iowa Tinnitus and Hyperacusis Clinic. I work under the supervision of Rich Tyler, and I'm not going to repeat what has been said today, and there's been a lot of really good, really neat things that have already been shared, but I want to give you the clinician's perspective. I want to share with you some of the things we do that we have found to be helpful and successful, so that you can decide if there's anything new or unique that you'd like to incorporate into your own practice. So I know there are some students in here today, and if I were a student now, the first thing I would do is try to get a hold of that script that is yet to be published, because when I went through school, we didn't really discuss tinnitus much, and I don't know currently what's being provided, but there is something really different, Rich, about providing oral rehab and the tools that we use for oral rehab as an audiologist and providing tinnitus counseling. And I can't really put my finger on it, but one is really daunting and kind of overwhelming if you've never done it. And so I don't know what's out there to really help you to understand where to start and how to do some of this. So let's see if we can be helpful today. Let's pretend like we're all clinicians in private practice, okay? And at Iowa, this is sometimes how our patients present. They're sitting in a consultation room, and all you have in front of you is their name, their address, and their date of birth. And you don't know anything more. So if this was your clinic, and you're going to walk into this room, all you know is that this patient is there because they have tinnitus and they're bothered by it. You can make the assumption that they fall into that smaller category, the individuals who are greatly bothered, and that's about all you know. So what information do I need from the patient in order for me to help them? Well, I really do need the audiogram, but I don't need it right then when I go to meet them, but I do need it because the audiogram is going to give you a lot of information about their hearing status, and you can use it as a tool when you're doing your counseling. So if you walk in the room and the patient doesn't have it, then that's a piece that I would schedule to have done. Maybe you can do it that day, or maybe they need to come back on another day. In our clinic, we have a diagnostic group, so I would schedule that for another day. If I'm going to do the audiogram, I would probably also incorporate in the tinnitus measures at that time. Do you need it to see that patient right there that day? No. But again, I think it's another piece of the puzzle, and it can be used as a good tool. I think it's very, very important that we understand the patient's ENT history. I believe our ENTs are our colleagues, and I really appreciate them. And if I walk into that consultation room and the patient has a rich history of ENT, that makes me understand that they are medically healthy. The ENT is the only professional who's been trained to spot the medical issues that could be unhealthy to the patient. If I walk into that consultation room and there's been no ENT visit, it doesn't stop me from working with the patient, but I really would recommend that the patient be seen by ENT. That's what we always do. Rich and I are always recommending that. Now, many times the patients will come back and they'll say, not everybody, but many times they'll say, that was a waste of my time or a waste of my money. And then I disagree, and I say to my patients, no, absolutely not. Having a quick visit with an ENT means that you are medically healthy. because the ENT looks at, and Dr. Hansen is one of our ENTs, and he's presented many times at our conference, he looks at the history, and he looks at the audiogram, and he has this whole list of things that he's thinking about and deciding on whether or not he's going to pursue more testing. So I walk into the room. If the patient has a current audiogram, we can use that. We need to understand their ENT history. And then I need, at that very first visit, some type of subjective data. I need questionnaire data so I can better understand where they're struggling, their areas of concern. And then I need to know what their goals are. So this can all be done in one tiny little session, and that kind of springboards and initiates all that you're going to do with the patient next, okay? So what, as a clinician, can you provide? And really all you can provide are tinnitus management options. I almost want to stop using the phrase tinnitus treatment. And I think the field should just say tinnitus management options. Wouldn't it be wonderful if the patient went to the ENT first and the ENT said, you are medically healthy, but you do have tinnitus. There's a person in town who specializes in tinnitus management options. I recommend you go see that person. Then there's no idea of treatment, cure, getting better in any preconceived way. So as you're setting up your practice or you're thinking about working with patients, it's really tinnitus management. We know that there's no medical procedure, there's no drug, there's no supplement at this time that can take the tinnitus away, but there are tons of options, okay? All right, what are those options? Very simple to you as the future clinician: sound therapy, tinnitus counseling, and any kind of combination. And if you really streamline it down to those things, then it can help you as a clinician understand how you can better help your patient. So how do you handle sound therapy? There are hundreds and millions of different ways these days you can provide sound therapy rather than just a little bit of, broadband noise. So this is what we do at Iowa. We actually schedule what we call a tinnitus sound therapy evaluation. It's 3 hours long, and we only fit and discuss wearable devices in that session. And this is our current inventory right now. So when a patient comes in, we actually fit them with just basic masking, if we can. And for some folks who have a significant hearing loss, a basic masker isn't helpful because they truly cannot hear. We can't make the masking sound audible for them. So we always have some type of combination device in our inventory. This can be any manufacturer that you like, that you work with, or you could have a couple. That's really up to you. And what you're going to do is you're going to not think about this session like you would a fitting audiologist who's thinking about better hearing, better speech understanding, but you're thinking about, are there ways to use sound to make that tinnitus a little less noticeable, a lot less noticeable? Is there a sound that can be used as a distractor? And so putting amplification in someone who doesn't have a significant hearing loss that needs hearing aid amplification can sometimes be helpful. So even someone with a real mild loss, even someone who has normal hearing, tiny bit of amplification sometimes is really interesting to see what happens. You always want to make sure it's a combination unit, so you can put in some kind of broadband sound or any kind of sound that you can frequency shape. All the manufacturers these days have that. You want to go in there and play with those features, and anything you can stream in, okay? I just happen to be a fan of the GN Resound Relief app. Like that app, but there's many out there that are good that other people like, but even streaming that in through any other manufacturer sometimes can be really helpful. So a basic masker, a combination device, and then we always include Witt as its own device. Because as of now, Witt is still the only manufacturer that has that unique fractal tone. And unless you literally fit someone with it and put it in their ears, you will not know what the response will be. Because you can have people come in and say, I heard it on the internet, I don't like those sounds, but when you use it as a technique, they can change their mind drastically. I like Neuromonics. Neuromonics has 3 devices. Get to know that manufacturer, they have good product. Desyncra is new to us, but I'm quickly becoming a big fan of that. They are unique. We'll let the manufacturers talk about that tomorrow, but they are unique in the fact that they aren't focused on masking or habituation. They are actually focused on treatment. And then I shouldn't have put Levo, I should have put Otoharmonics. We have added in that device as well. So 3 hours, fit these, play with them, try them on. And most patients leave knowing, hey, I really don't want sound therapy. Or some patients will leave saying, I have 3 things I really, really want. Now I need to go think about it, okay? I don't know how to linearly put into tinnitus treatment all of these devices. I really don't know how. I really think you have to have a single isolated evaluation session where you can try these because each patient is so unique. So that's what we do here. Yeah.
What do you bill for that?
Well, we can talk about that later, but it's all out of pocket. There's no insurance coverage. Yeah. So some patients say, I don't want anything to do with a device, but they are interested in counseling. We provide, and I really encourage you in the field to use the term tinnitus counseling. We are audiologists, we can do it. We're not marriage counselors, we're not psychologists, we're not focused on anxiety and depression. We are literally providing counseling in the area of tinnitus. And at Iowa, we offer individual sessions. We can bundle individual sessions at a reduced cost. We do provide telephone counseling, and we can do all kinds of combinations. Okay? Okay. Set a goal for every single thing you do. If the patient's coming in for sound therapy, what is their goal? Do they want to notice their tinnitus less? Do they really like this term habituation, and what does that mean to them? Do they want to lower the level of their tinnitus? Are they really anxious and they want some relaxation? Are they looking for relief? If you don't know what they want, you're going to just get caught in a silly little cycle, and you're going to be trying on devices just for the sake of trying on devices. When I think about tinnitus counseling, I noticed this year that Dr. Tyler and Ann Metmore published in a trade magazine a little article, and I'm going to take this quote from her. What is important when working with a tinnitus patient is the willingness of the therapist to really listen and to really understand the patient the way they hear and perceive themselves. And I think that was already nicely addressed this morning. She says this is done by asking questions that lead to a deeper understanding of why tinnitus is accompanied by so much suffering. And I noticed that Bev, in her mindfulness talk, used the term suffering also. And I almost wonder, and I'm starting to do this with some of my patients, when I'm meeting them in that first session, asking them outright, what is your suffering? Because I think that might get quickly to the heart of why they are there. And I'm going to say this, and I might be going out on a limb. I'm convinced that that small population of people that are greatly bothered by their tinnitus may be a unique subgroup of tinnitus patients. And there may be characteristics that they have that might make their suffering greater. But I would love to take their tinnitus and put it in someone else who's in that bigger group, and take someone in that bigger group and drop their tinnitus in that person and see what their perception is. So when I work with these folks, I really do go in with the mindset that they have a unique subcategory of tinnitus that we can't understand yet, and that their suffering is real and great, and we shouldn't ignore it. Okay? Okay, so what do we use here? We use what we call this tinnitus activities treatment approach, and it's simply a picture-based approach that covers 4 areas. So the questionnaire of choice for me is a 12-item questionnaire that we developed here, and it's called the Iowa Tinnitus Primary Functions Questionnaire. So think back to that patient that's sitting in that exam room. All we know is their name and their address and their date of birth. We walk in, I introduce myself, I ask them to fill this out, I step out, maybe 3 minutes at the most, step back in, thank them, and I take it out. And I know in that short amount of time where their suffering is. There's 12 items. Without even reading the items, I'll tell you that the scale is 0 to 100. 0, they are less bothered. 100, they are greatly bothered. Okay? It's broken down into those same subsections: concentration, emotion, hearing, and sleep, because these are the 4 areas that Dr. Tyler feels are most greatly affected. So this is a questionnaire from one of our patients. Without knowing the content of the questions, you can clearly see this person is struggling. They're struggling with concentration. They're struggling with their thoughts and emotions. They're not hearing well, and they're not sleeping well. This person also is on the higher end of that scale. This person, wow, look at the sleep score. That's the very bottom one. They're doing pretty good there. Look at the very top one. They're not struggling with concentration, but they're having some issues with their thoughts and emotions, and they're not hearing as well as they probably want to be. This is a person who really is struggling with sleep. Look at that 100 at the bottom, and then look at how they're feeling emotionally. Whoa, this person, no concentration problems. They're hearing just fine, but man, they cannot sleep. And I think that's what's maybe causing some emotional issues. And then I think this is my last one. Boy, this person really is struggling with concentration, so something's going on there. So I can almost look at this questionnaire and figure out where they're suffering if we use Ann Metmore's description. So then I can go back into the room, and then we can actually start in that first session. If they have the audiogram, we've got it there to get started with some of that directive counseling, okay? If not, we're going to recommend they get that. We schedule that for another day. We talk about ENT history. We talk about what they're struggling with. We're starting to get to know them. We lay out options. We explain to them what sound therapy is, what counseling is, and right away, we've got a game plan. If you want to know more about this questionnaire, all of my slides you'll have access to, and this is the study that was done to look at the development and the validation of it. Okay, this has already been mentioned, but the Tinnitus Activities Treatment is a counseling and sound therapy-based program. It's picture-based. We already said there's 4 areas we focus on. It's provided for free on our website. As Rich said, pictures, it helps you with orderly fashion so you don't forget concepts. I think of them as little mini lectures. If you wanted to do telephone counseling, you could have the patient pull up the slides from their end, and you can do that over the phone as well. This is where you can find the slides. There's the link. You'll see all the different sections, and notice at the end of each section, there's a review. So you can take that review and use it at the next session to go over what you've done and to discuss any homework. Okay? Okay. There's no right or wrong way to use these pictures. There's no specific order. Go through all of them. Make sure you feel comfortable with them, and be aware that there are some topics in one area that you might use in another area. The area where I think these folks that fall in this small subcategory spend the most time is in the thoughts and emotions section. And we all do a great job here talking about what needs to be done, but it is hard work. These are not easy concepts. It's not easy for everyone. As Bev mentioned, it's a process. When I meet and greet my very first patient, I always try to give them a time frame so they can put into perspective what they're looking at. And I always tell patients, give yourself 1 year from the time in which you actually start meeting with a tinnitus professional before you assess, is anything helping? Now, of course, along the way, you're going to be assessing that. But that gives people an idea, a time frame, because I think a lot of people are looking for a quick fix. And in the world of tinnitus counseling and tinnitus management, I don't typically see quick fixes. We can, but not always. You can use any and every slide as a handout. There is a tinnitus diary built into these slides. There are tons of slides with handouts incorporated onto the conference website in the section that I'm covering. So go there and take a peek at all those. The introduction is where I typically start, and that's that first day walking into that consult room with that patient. We always set aside at least an hour, and you should be able to get through in 1 hour that questionnaire, a discussion of other measures that might be needed, and then allowing yourself to just sit and listen to the patient's story. And again, I think that was covered nicely this morning in our talks. But this is the only time that the patient really can start to feel validated, because you are pausing, you're listening, and you're asking them to explain what's been happening to them. They don't get that with the ENT, and they shouldn't. And they don't get that in a busy audiology clinic where you're fitting hearing aids. And their story might not be unique to you because you've worked with lots of folks with tinnitus, but it is unique. And this is where you can really start to build that relationship for all the next sessions. So as Rich mentioned, there's lots of slides to go through. Sometimes I don't even need to use these, but if you want to, they're there. And the slide, how do you think we might be able to help you, is where you can really start to document goals. And I tend to push a little bit with goals. So I had a patient just 2 weeks ago. Her goal was to get better. And my response was, that's a wonderful goal, but it's too broad for me. What does get better mean? And she just struggled, get better. But I don't know what that means, get better. Until we went back and forth, and finally she started crying. She said, I can't hear. I want to hear my husband better. Okay, that was the first place. I had the questionnaire. I could see she's not sleeping. So then I said, what about with sleep? I want to, sleep better. So really get these goals down into real good, concrete steps that you might take next. I want you to be aware that in the thoughts and emotions section, there are many, many parts, but the very first part I think is really critical, and I think it's where we do our directive counseling if I'm thinking about how you guys presented this morning. And that's the hearing and hearing loss section. And this is the part where you're going to feel the most comfortable and the most confident going in, because this is where most of our training comes from. And so I think all patients, regardless of whether they go on to do sound therapy or additional counseling, need to have this section. It's where we remove the unknowns and the misconceptions and the fears. This is where we use the patient's own audiogram. The more detailed, the more better. Last year I said to you guys, I want you to go home and ask someone in your family if they have an organ of hearing. Because as an audiologist, I had to do that, and I was shocked. No one in my family even knew we had an organ of hearing. And then when I said, did you know we have two? They didn't even know that. So we know this information, but our patients don't always. So we need to take the time to teach it like you would a student, okay? And there's lots of slides that we provide, so you have a springboard to discuss this. And I'm just, quickly going through these, okay? And Rich has already discussed a lot of them. Okay, so now I'm going to jump to sleep. Pretend like this person we're working with is very sleep deprived. This is just my clinical observation that I'm sharing with you. I find that the patients who have sleep issues are sometimes the patients that I worry the most about, and can tend to be the patients who perhaps end up with a hospitalization and or attempt to suicide or possibly even suicide. So if I give that questionnaire and I see sleep as a real issue, I tend to start to talk about that quickly and first. I don't feel competent and comfortable as an audiologist managing sleep alone by myself. When you are sleep deprived, if you've ever been, you may notice that all of your senses feel like they are on overdrive. You're touchy, you can be grumpy and short with people, sound in general can bother you, lights can bother you, and I just think it makes everything harder to manage. So when I see the sleep getting better, sometimes then I see some of the other things start to sort out. So if I see someone with a very high score in sleep, I ask them straight out if they have an MD that they work with, that they know well, who is understanding of the fact that they're not sleeping. And if they say no, I ask them to please consider having that discussion with their MD. I like to have patients sign a consent so that I can communicate with that MD, so that I have a medical professional who can help guide this person. Because these are the patients that I fear may hurt themselves, and I have no proof other than my own clinical experience seeing patients hurt themselves. I can't recommend medication, but I can let patients know to be open to having a discussion with an MD. Not that all MDs are going to talk about medication, but they may want to talk about supplements, medication, holistic approaches that might parallel what I'm doing. But I really think we need to take that component very seriously. So what can I do? Well, we need to give basic information. We really need to understand this person's sleep patterns and what they're experiencing, and at a minimum, we can discuss with them what's called sleep hygiene. And we can make sure that they're adhering to basic sleep hygiene rules, and if they're not, we can make the suggestions that they adjust them. And if you don't know what sleep hygiene is, you can look through our slides, but do a little research on your own. You want to talk about what's a normal sleep pattern, what's an abnormal sleep pattern, things that affect sleep, what to do during the day to facilitate sleep, what to do at night to facilitate sleep, how to prepare, when we should be waking up, should we be attempting to fall asleep, that type of content, okay? So our sleep section is full of really good information. I also think you should, at this point, introduce progressive muscle relaxation and imagery training. And you can do that in any form that you like. Almost every manufacturer these days has great information on their websites or in a flip chart form on how to do these procedures, and I would practice them right there in the clinic with the patient. and get them started on this. The other thing I like to use is this worry diary idea. It's not easy, but when it's used, it can be very helpful, and that is having a place to place your worries, conditioning yourself, training yourself that when they pop up, to take them and put them somewhere else. I have in my bag a bunch of books and extra handouts that I have found to be helpful over time. I'll have those out at my breakout session. There is a new book that I'm a little bit addicted to about worry, because I do think sometimes when you have someone who's having sleep issues, that underlying that can be some worry. And so if you come to my breakout session, I'll share that with you and show you that. When we think about sleep, if you've heard me talk, you know I always say the person with tinnitus trumps the spouse. So whatever you need as a tinnitus patient to sleep well probably needs to take precedent, and it's okay. And I find this really interesting. A lot of times we have to almost give permission to our patients to sleep separate for a while, or sleep in another room, or the wife will say, well, I can't stand all that sound he's got going on. Well, then don't sleep in there. You don't have a sleep issue and you don't have tinnitus. So start to have those conversations, but I really feel like our purpose is to help the spouse understand that they need to be very respectful during this time. Okay, so let's pretend like our patient sitting in that consultation room is struggling with concentration, but they're sleeping well. So then I'm a little less concerned. I'm more relaxed because I know that they're getting some good sleep. What do we do in the concentration section? Well, we talk about what is concentration, why is it important, things that affect it, how our tinnitus is affecting it, and we need to get really specific about what they are struggling with. Because many people will say, I can't concentrate. And I don't know what that means. And again, I say that. What does that mean? Well, I can't concentrate. What does that mean? Well, I can't concentrate. Can you read a book? No. Can you watch TV? Yeah. Okay, so I can't concentrate is too large. We have to figure out what the issue is and then what could maybe be tried. And you don't have to have all the answers, but maybe in that session you can at least try to sort out what they're bothered with, tell them you're going to take some time to think about it, and come back at your next session with some suggestions. One thing in our concentration section, these again are just examples of our slides, is that I think it's really important that we look at their work habits. Can they make any adjustments? What can we change as far as tasks? If you can't read, have you tried books on tape? Have you tried downloading? No, not a blog. What is it called? Podcast. There we go. I just did my first one. Clearly, I don't know the technology. Podcast. Let's ignore what we can't do right now, and let's focus on what we can. And can we get this information in another way? Okay. Take a good look at the tasks that the patients are doing. Sometimes when you can't concentrate, doing something really simple and routine feels good. But sometimes when you can't concentrate, it feels better to jump into a novel. And so try some of these things and see where the patient's at and just, kind of guide them. You can look up in cognitive psychology this idea of divided attention theory. I do think maybe some of our patients present this way where maybe they're having concentration problems because we only have so many resources, and maybe the tinnitus is really taking up a lot of those resources. I see a lot of patients with poor memory. Shelley, I've never had memory issues. Now I have tinnitus and I can't remember a thing. So I'm wondering if it has to do with where our resources are being allocated. And have that conversation with the patient. Okay, the next section, hearing and communication. Remember some of those questionnaires where they were sleeping okay and they could concentrate, but emotionally they weren't feeling so good because they didn't feel like they could hear. Maybe those are the folks with a really good audiogram for a hearing aid and they've never gone that direction, and that's okay. This section should be very simple for all of us. This is where we've been trained to talk about what affects hearing and communication, how we can adjust to the people around us so that we can better communicate. I have a home with 500 million televisions, and every single television is on with a different show at a volume level that is obnoxious. And when I come home at night, I have only 2 children and 1 adult in that house, but the sound level is overwhelming to me. It's my job as the person who's struggling to hear my family to guide them, to tell them what I need in order to hear them better. So almost always the first thing is, I'm sorry, Derek, I cannot hear you. I need to turn the TV down. Now let's start again. Or my son who mumbles and has a really low voice and walks right past me. It's my job to stop him and say, honey, I didn't hear what you said. Stop, tell it to me again. If I don't hear it, or I hear it but I don't understand it, then I tell him that. I didn't understand what you said. Can you raise your voice? We as clinicians in this field should feel really good about this section because I think we're trained really well to be able to provide this. So these are some slides that go with this section. I love to talk about the fact that we need to teach our patients how to be assertive, less passive, less aggressive, and these same styles can be used for how they're managing their tinnitus. If they're seeing their tinnitus as some type of a threat, are they fighting it? Are they getting aggressive with it or with the situation? Are they become really passive, and are they feeling very victimized and they're not moving forward on trying to make changes? So I really love this slide, and I think we can use it in that aspect. Of course, communication repairs. And then now I bring us back to thoughts and emotions. We can talk all day about this section. I have just a few more minutes left. We'll bleed into what I'm going to talk about tomorrow, okay? Because this is where I think we're not properly trained. We're maybe getting there. If we all get the script, we may be better equipped. But this is where I think the real work is. And I think if you feel very uncomfortable with this, have a good resource to refer out. But my experience has shown me that we as audiologists do a better job than our colleagues in psychology because they don't have the hearing background that we have. Now, we can work together with a patient, or we can see the patient first and refer out. But when we just give up and refer out, I see people cycle around and then end up back in the clinic. So this is where I think we need to really spend all of our time. When we talk about thoughts and emotions with our patients, we need to have a really good understanding, and you were doing a really great job with your slides on types of attention, how things capture our attention, how we direct our attention, why we can ignore some things and not others. Have a really good understanding of how to share this with your patient, and then have some techniques that you can use with them. So I'll take 2 seconds to run through this. As was mentioned earlier today, we have a conscious and a subconscious. Our conscious is what we're supposed to be paying attention to right now, which is my voice. And subconscious is what's going around at the level of the brainstem with every other stimuli around us. Rich has worked with me for 100 million years, so I bet you I'm not up here in his conscious right now, but I could be wrong. There could be something else up there. And some of you are being very distracted by some subconscious stimuli right now, okay? We all have experienced this where you're somewhere and you're focused on something and you go, did I hear my name? That's a beautiful example of stimuli going from the brainstem all the way up to the cortex without any control that you have, right? That's kind of what the tinnitus is doing. We want it down there, but it's going up here, right? And so how do we help get it from there back down? Some things we cannot, and those were all slides that'll help you have that conversation with your patient. Some stimuli we cannot ignore. That example of someone saying your name was a good example, but if there were a catastrophe right now going on, no matter what I say, you're all going to focus on that catastrophe. That's tinnitus. When it's unusual, if it thinks it's important, or we think it's important, or if it's scary, or if it's unexpected, it goes from there to here. And then we do something with it. We create connections to it, and we give it power, and then we suffer. So where do we break that cycle? We can start with some basic attention control exercises. And there's a book that I'll have in my breakout session that I think is wonderful, that has great examples that you can just lift and use. We can take some time to really talk about the thoughts that we have and how they're connected to our emotions, okay? So Bev said something earlier today that's true. We have all kinds of thoughts going on at any given time, and they jump from thing to thing, and we can't control it, but we can when we want to, right? But all those thoughts only fall into 3 categories. At any given time, our thoughts are either positive, negative, or they're just neutral. So when that tinnitus is here, and we're living life and we're good, and then something happens to it and it goes up here, one of our jobs is to neutralize the thoughts that we create, okay? So to understand this, we have to first be aware of our thoughts. To help us understand this, I'm going to ask you to do something in a second, but I don't want you to do it yet. When I tell you to, I want everybody to get up and find someone they absolutely do not know. And I want you to make plans for lunch tomorrow to eat with them. But before we do that, evaluate your thought real quick. Don't get up, evaluate your thought. Some of you are saying, oh, I love that idea. I'm here to meet new people, and I think that's wonderful. And that's a really positive thought. And what does that positive thought do to your emotions? It makes you feel better. And some of you immediately went into the negative category and thought, are you absolutely kidding me? Do I really have to do this? I do not want to do this. And I don't know who Shelley Witt is, but I do not like her. And how did you feel? Right? Your emotions go the other way. I'm not going to point fingers, but I saw someone go. And I don't know if anyone had a neutral thought. It might be the gentleman who's videotaping us who looks like he's half asleep, who just smiled. He's like, I'm not listening, so I'm neutral, right? So if you as a clinician can even have one goal, and that is to help uncover your patient's thoughts, help them understand how it connects to their emotions, and then see if there's a way to neutralize them or change them. So I'm not going to make anybody stand up, and no one's going to have lunch together tomorrow unless you want to. But that's a great example of how there is a connection. And I really think if you can spend time showing your patient that connection and understanding that connection, then you can start to make changes with the tinnitus. I think underneath the suffering is a lot of internal negative self-talk that the patient may not even be aware of. Okay? All right. So, real simple, if you're sitting with the patient, this slide just says you have to understand the connection. We have a thought, we have an emotion. Rich gave this example. You can use this in your session also. It's just a sound and an experience and then a thought and then an emotion. Okay? We have to find the unhealthy ones. This is a great slide. Print it out, set it on the table, and all you have to do is show it to them, read it, turn it upside down, and say, I'll write, but you tell me what kind of thoughts have you had about your tinnitus. And I'm telling you, you will write and write and write. It'll all end up in that negative category, and that's your first place to start changing some of that. Okay? Once we identify them, now we have to restructure them. And that's the hard part. It's kind of like what Bev said. When you're trying to control where your thoughts are going, you're trying to be mindful, and next thing you know, you're planning dinner. Okay? So this is a process, and this is where the work is. But when you do the work with the patient, you can see great things happen. Okay? This is a simple example. How does this thought make you feel? I hate this. How does this thought make you feel? I can't. How does this thought make you feel? I don't want to. Versus, this is okay. I can do this. I had lunch with an old friend today, and I think this is how we've lived our whole life. I can do this. I don't like it, but I'm going to do it, and I'm going to do it right. Last year I shared this with you. I saw this at an elementary school, and teachers were doing this. Well, teachers aren't psychologists. Well, teachers can do it. Audiologists can do it. This was up in one of the hallways. I'll never be as smart as her. And the flip to that is, I'm going to figure this out. I can do this. I can't read. I'm going to learn to read. This also blends into one of, I think, the most powerful tools you can give a patient. So let's go back to that first visit. You walk in, all you know is their name and their address and their date of birth. You have them fill out your small questionnaire. You see where they're suffering. They didn't bring an audiogram. You schedule that for another day. You talk a little bit about ENT. You start to talk about their goals, and you start to notice a lot of negative feelings. Maybe there's tears, and this is overwhelming. You set the stage. You tell them, give yourself a year. Let's see what we can do in this time frame. And then one of the most powerful tools is assign them to create their own mantra. Because ultimately they have to become their own coach, right? So they have to come up with their own phrase that is either neutral or positive. Give them one example, and then let them start creating their own. So, I can do this. If they start to use that, and I'll even say this to yourself 100 million times all the way home. Because what you're doing is you're starting to neutralize. Take away some of that stuff up here that's helping keep the tinnitus right there. This is one of my favorite slides in the whole wide world. I use this a lot with patients. To me, it represents their journey, and it represents what you are trying to help them do. When tinnitus comes into their life, there's a lot of negative thoughts, and we already know just by this little talk, negative reactions. The more we attack the thoughts and try to adjust and change those, the more constructive our thoughts become, the less negative our reaction, and then we're just maybe more anxious and irritable. And as we do this more and more, this becomes less and less, and this is eventually where we want to be. But does this happen in a linear fashion? No. Circles and circles and circles, and you might be here for a while and circle down. You might be here for a while and then something happens and you circle back, but it's a really nice visual of where you want to go and what you need to do, and it all starts with those thoughts and emotions. Okay? I have 5 more minutes. Let's say you have someone and they really can't do this, and they're not ready to do this, and they really think you're a quack. They don't want to go there. They just want to fix it, fix it. You can't, but what you can do is, hey, let's get them focused on a completely different area of their life. Tell me your hobbies. What do you like to do? What can you still do that you like? What can't you do? Well, if you can't do it, then let's ignore it. Maybe your first homework assignment is whatever you know is going to make them happy, do 10 times before I see you next. That would just be refocusing, okay? And this is a slide that could help with that. And then lastly, before we have to quit for today, is maybe they don't want to do that sound therapy evaluation yet, or maybe they do, but you can't schedule it for another week or so. What can they do on their own to help reduce the contrast between their tinnitus and the world? Introduce sound therapy in non-wearable ways. And that would be your desktop fans or your desktop machines, or this is where I think those apps can be helpful. As long as they understand what the reason for it is. Can it give them a little temporary relief? Can it be done in a way that's helpful? I like to give an assignment called sound searching because it gives you control. It gives you the ability to go do something and ask your patient to take the time for the next week to search for what sounds are pleasant to them, maybe mixes with their tinnitus nicely. You know, a long time ago, you could send someone to Barnes & Nobles and you could put CDs in or wear headphones. I don't think you can do that anymore, but you can probably download music and take some time to listen to all these different apps. And the Resound app, you can adjust your sound and you can make changes. And I'm not asking you to go find your sound, because that's what many patients will do. They'll come back and say, I found it. This is what it sounds like. What I'm asking is, what sounds mix well with your tinnitus to make your tinnitus maybe just this less noticeable? That would be a good homework assignment.